Today's seminar, Aging in the Right Place, is part of the MIRA One Topic, Two Disciplines series, which brings together experts from two very different fields to discuss important, complex topics in aging research. This series is aligned with MIRA's goal of supporting interdisciplinary collaborations among aging researchers at McMaster. Today, Gina Agarwal and Jim Dunn will bring their expertise to address questions around how housing, urban policy, and design can enable older adults to age well in their communities. Jim Dunn will be our first speaker. He's an urban geographer and professor in the Department of Health, Aging, and Society at McMaster, and the Senator William McMaster Chair in Urban Health Equity, as well as the director of McMaster Institute for Health Equity. He believes in the importance of building environments that allow marginalized populations, including older adults and people with disabilities, to navigate through their neighborhoods. He studies living communities as they undergo transformations and explores how built environments affect the mental and physical health in neighborhoods and communities. His research programs focus on how economic and social policies influence the social aspects of population health, as well as the importance of building accessible communities which can directly affect the health and mobility of people living in those communities. After Jim speaks, Gina Agarwal will talk to us, and she's a professor in the Department of Family Medicine at McMaster. She's the inaugural Levitt Scholar and the Senior Medical Advisor of the Hamilton Health Sciences Community Paramedicine Program. Gina is the Principal Investigator of the McMaster Community Paramedicine Research Team and a practicing family physician at the McMaster Family Practice. Her research focuses on improving health systems for vulnerable populations. Gina is committed to ensuring adequate care is provided at the right time and place to those most in need. Her most recent research with the Community Paramedicine at Clinic involves paramedics holding drop-in sessions at select subsidized housing settings, high numbers of 911 calls. I would now like to hand the reins over to Jim, who will speak first, followed by Gina, and we'll take questions at the end of Gina's presentation.
Terrific. Thank you so much. Thank you very much for having me. It's great to be involved in this, and really looking forward to any discussion that we're able to have afterwards. And I want to say, just begin by saying that I'm going to give sort of a bigger picture kind of perspective, and then Gina is going to do something that presents something more detailed about her research. And so this, what I'm going to talk about today is kind of an evolving perspective on thinking about the connections between the health system, aging, and housing. And my real expertise is in housing, and I don't really have that much expertise in aging. So you may hear some stories of where I cottoned on to things in ways that were obvious, that should have been obvious to me, but weren't. And so anyways, just warning in advance that if you may say to yourself, gee, Jim, that was obvious. Can't believe it took so much for you to figure that out. But at any rate, as I said, my perspective really comes from a housing perspective, and I want to talk a little bit about the intersection of those things and do so in a population-based way. So thinking about scale. And, you know, I don't think anyone in the audience is immune to the discussion these days about crises in affordable housing. And I think that just kind of emphasizes the importance of this. And one of the biggest challenges in terms of addressing these crises in affordable housing is actually doing things at scale. So there's lots of interesting little innovations that occur here and there. And one of the things I'm concerned about is identifying what's the scale of action that we need and how do we actually achieve that scale of action. So I'll emphasize that a little bit in my presentation. So, you know, at a very rudimentary level, the question I want to address is, where will older people live in the future? And in order to answer that question, we really have to confront the question of how we must adapt new and existing urban infrastructure. And when I say urban infrastructure, I'm not talking just about bridges and sewers and that sort of stuff. I'm actually talking about housing as a critical piece of urban infrastructure, transportation, and so forth. And how do we adapt this new and existing urban infrastructure to the needs of an aging population at scale? And the things that, in my view, we ought to be thinking about is how we achieve housing options for people that keep them independent and out of institutions unnecessarily. How do we achieve transportation options for people? How do we ensure that services can be delivered to people? And how do we ensure that that people have social relationships that are going to sustain them? And to me, the big challenge is one that I kind of see through the lens of the Greater Golden Horseshoe. And the Greater Golden Horseshoe is essentially from, Whitby all the way around the Horn to Niagara. And in that region where we all are, or most of us, I imagine, are, currently there's about 350,000 people over the age of 80. And by 2041, it's projected that there will be 1,050,000 people over the age of 80. And that's an extra 700,000 people over the age of 80. And I know often it's common to talk about percentages or ratios of older people to younger people and that sort of thing. I'm actually interested in the raw number. The raw number is an extra 700,000 people who are going to live in areas that are largely car dependent. And we'll talk a little bit more about the importance of that in a moment. There's a number of questions about how smaller cities will cope with this the aging of the population. And really, I think it's imperative for us to think about not only can cities become age friendly, but also age optimizing. And one of the things that's really kind of a wave at the age friendly cities movement, which has achieved lots, but is not well suited to forcing decision makers to ask questions about the physical infrastructure at a large scale. It's more focused on services and inclusion, which are all very important, but it really doesn't force these bigger questions about the urban infrastructure and the physical nature of it at scale. So one of the things that we're concerned about in this world is healthcare costs, and what we find is that a very large number of healthcare is consumed by a very small number of people, and that's something that that has been pretty consistent over time. And I'm going to draw a connection to a concept that was actually very nicely summarized in this article from 2016 in an online urban magazine. And it simply says, our infrastructure fails seniors who don't drive. And that's a problem for everyone, sorry. And that's a really big issue because, and we'll talk a little bit more about that in a moment. And at the same time, we know from COVID-19, we've seen it's revealed some very large problems in long-term care that were relatively invisible, at least to many of us, as well as in retirement homes. And this is indicative of a larger problem of housing and aging. So as I said, the 80+ population in the Greater Golden Horseshoe is estimated to increase to 1.05 million by 2041. And ultimately, to me, the cornerstone of my perspective that links housing to the healthcare system and other institutional forms of accommodation is that housing is always some combination of accommodation and support. So if we think about all of the things that we consider housing, and here at one end of the spectrum, you might think about the single detached dwelling in the suburbs. That provides accommodation to people, obviously, but it also provides supports. The supports are someone comes and takes the garbage away, the waste is taken away by the sewers, clean water comes out of the tap, and so on and so forth. So there's accommodation and support. And at the other end of the spectrum, acute care hospitals also provide accommodation and support. So people stay overnight, they're accommodated overnight for the length of their stay.
Room service.
Thank you. Sorry. And they're accommodated for the length of their stay. And they also receive supports, but they receive acute care supports. And so one of the interesting things that was a bit of a light bulb for me in thinking about this was several years ago, HHS and St. Joe's were doing an initiative where they were trying to find housing for people who are medically complex but non-acute. And they are essentially people who lived in hospital. They used the patient waiting rooms like they were their living rooms. They had pictures on the wall, and they were literally living in acute care hospitals because that was the only place where their medical complexity could be addressed. And ultimately what they did is they managed to find some housing providers who could deal with their medical complexity, and they didn't, because the hospital doesn't want them there. They're considered alternate levels of care. So there's a whole variety of people who end up in institutional care that don't necessarily belong there. And the reason they often don't belong there is because there's no housing and supports, accommodation support combination in the community that can actually meet their needs. And so that ends up as a default that they end up there. Another example is long-term care facilities. One of our partners in my research is an organization called Stillbrook Affordable Retirement Residences, and they were established by a man named Peter Nord, who used to run the stroke rehab clinic at Providence Healthcare. And Peter started Stillbrook Affordable Retirement Residences, which is an affordable housing and support provider. He started it because he had patient after patient come through the stroke rehab clinic, and when it was time to discharge them, they had all these services that they were available to them in the community in terms of home care services, but they couldn't be discharged to the basement apartment with 6 stairs down. And their option was either go to Rivera or Schlegel for $6,000 a month and live in a supported apartment, or wait for a long-term care bed. And the only thing they could afford was the long-term care bed. And so they waited for the long-term care bed. And so you had a number of people who didn't have housing. Gosh, this is the worst I've ever had interruptions in a presentation. Sorry about that, folks. So basically what was happening is people were ending up in long-term care as a form of affordable housing because there was no affordable housing available. And ultimately the reason Peter started Stillbrook was to, goodness me. The reason he started Stillbrook was to, was because that was the missing piece of the puzzle, was that there was no affordable housing for these folks. So at any rate, as there's also a gap in purpose-built options of people's of housing for people in their housing career. And so in housing studies, we talk about people's housing careers over their lifetime. And ultimately, there's a gap between clinging on to the single family home until you pass away or need something else and an institution. In other words, our housing careers, if you like, are set up so that the pinnacle of it is get the ground-oriented single detached or townhouse or row house kind of accommodations. And that's pretty much the housing for 75% of the population in the Greater Golden Horseshoe. So the usual model is people get that and then they cling on to it until they pass away or they need something else as almost as a desperation measure, being a retirement home or a long-term care facility. And the problem is that because the population is going to grow so much, the small minority of people who outlive the cling on to the single detached dwelling is going to grow immensely. That number of people who need that is going to grow immensely. And ultimately, clinging onto the single detached dwelling, which is often called aging in place, can mean that people are stuck in inappropriate accommodation. It actually curtails the length of their independent life. So they can paradoxically be less independent if they cling onto the single detached dwelling when there might, in the absence of other options. So this is what we talk about in the housing world, about the housing career ladder. And so, it starts with living with parents, and then independent household formation takes place, and people become private tenants, potentially a public tenant. This is a very UK perspective, first-time buyer, second-time buyer, et cetera, et cetera. And these things change as people's work and family lives change over time. And then occasionally they talk about people falling down the ladder as well. And the thing is that, and I've augmented, this is from Kendig and et al. And what I've done is I've actually augmented it with the kinds of the built form that we see in this housing ladder. And clinging on to this might not be a long-term key to independence at a large scale. Now, it turns out, having thought through all this through my pathway to get there, I found that other people had thought about this. And so this is a really interesting figure coming from the US that shows that as function changes over time, that people's housing circumstances ought to change over time, that the costs change over time, and that the public benefits and resources also change over time in terms of a life cycle perspective. So I think this is, again, something that gives us an opportunity to think about how these things are changing over the life course. So if we think more broadly, though, about urban infrastructure and aging, as I alluded to a moment ago, we live in a highly car-dependent, low-density urban form in this region. And we've had tests for people over the age of 80 needed to prove their driver fitness for some time, but those were made harder about 4 or 5 years ago. And because they introduced cognitive testing, in addition to just rules of the road and vision testing. I'm not sure exactly what impact that had on people losing their driver's licenses. But the thing is that the thing that concerns me is that the number of people over 80 stuck in the suburbs without a driver's license is poised to grow quite quickly and grow to a quite large number. And that poses a number of problems in terms of delivering services to people, and also people actually getting transportation to the places that they need to go. And it actually significantly curtails their independence if they're stuck in the suburbs without a driver's license. And so the burden of care of just driving people around could actually become quite significant as well. So, and then in terms of public policy, the cost of providing public transportation to replace seniors' car trips in the suburbs is very, very high. So I had a conversation with someone in public health in a suburban municipality 6-7 years ago easily, and they said that they were already doing dial-a-ride in this particular community with the transit system, where you can call up and a bus will come, essentially a mini bus will come and pick you up. And the counselors were already really concerned about the cost that was already having for them. And that was only the beginning. And ultimately, we need to think about how we can adapt people's environments to their function, because the level of disability that people experience, and this is the classic equation of universal design, the level of disability that people experience is partly about their functioning, but also about their environment. And so what would be the ideal urban environment to maximize people's independence for as long as possible? And how do we create that and do so at scale and give people trustworthy pathways to get to those kinds of housing options is ultimately the thing that I'm interested in. And one of the other problems of this is isolation that comes from having a lot of people in the suburbs with no driver's license, and it's quite deadly. I mean, social isolation is literally deadly. There's lots of studies that show that, and there's an increasing concern about particularly low-income men who are at high risk of isolation. But I mean, it affects all genders for sure. Now, again, in terms of transportation, as much as we all think we might be able to get around like this as we age, the reality is quite a bit more like this. And winter is a big factor in all of this. And so to the extent that we're able to essentially control the winter conditions and it's going to be a huge factor as well. So I'm going to wrap up now shortly, and I want to just kind of leave you with a few questions. And the big one is, how can we plan our cities so that they promote greater levels of independence for older people for longer, and do so at scale? Can we achieve age optimizing cities? And to the extent that we need to move resources around, how might we do that? And I reflect, I was fortunate to get invited several years ago to a meeting with a man named Nareev Shah. It was a few people in Toronto, there were about 6 of us, and it was just a Q&A. And Nareev Shah at the time was the State Commissioner for Public Health in New York State. And it was just a Q&A sort of meeting. And so when the floor was open for questions, I piped up with the first question, and I said, well, let's start with something broad. What are the 2 most important things that you're working on right now? And he said fracking, actually, and they later New York State banned fracking. But the thing that really surprised me is he said supported housing. And I said, what? Your number 2 priority, or top 2 priorities, includes supported housing, and you're the State Commissioner for Public Health? Why? And he said, because I manage the state Medicare and state Medicaid budgets. And it costs this much to keep somebody in a hospital, this much in a long-term care facility, this much in a retirement home, this much in a jail, this much in a shelter, and this much in supported housing. It's a no-brainer. He said, it's just a matter of dollars and cents for me. And so to me, that's actually ultimately where we ought to get. And there's some optimism that the Ontario health teams might be in a position to break down the silos between different sectoral budgets to allow some of those economies to be realized, where we've got people in hospital and long-term care facilities who are using them as housing and could actually be more appropriately accommodated in what we would normally call housing with appropriate supports. What would age optimizing neighborhoods also look like, I think, is another question. Housing, transportation, social opportunities and services. And you know what? In a lot of ways, Hamilton, with the recent final approval of the LRT, is well positioned to be such a community because of the transportation that is there and the opportunities to build along the LRT line in ways that could allow people to have transportation independence as well as housing that is appropriate to allow them to be as independent as possible. And then how can these kinds of changes be marketable, affordable, desirable, and culturally appropriate, and at the same time balance the dignity of risk? So there's quite a number of loud voices, I think, that are entirely appropriate to say that, you know, we spend a lot of time avoiding risk for people, and it's undignified for them, and that people need to be able to take risks. And basically what we want to do is encourage housing options that allow them the independence of being at risk, but essentially providing options for them to minimize it at the same time. And what also would we make of such a built form for future use after the baby boom is over? Because if we think about a 100-year life cycle for most buildings, we need to think about the future use as well. There's lots of synergies with other agendas on this as well, and I won't go into details about those. So, you know, as we kind of make the case to decision makers, it's, you know, these kinds of changes and changes to the housing options that are available has lots of other potential impacts as well. So thank you very much for your attention.
Thank you, Jim. And I'll allow Gina to just get her slides up. We have a couple questions in the chat box, but we'll just hold those until the end. So. And whenever you're ready, go ahead, Gina.
Okay, so you can hear me. I'm unmuted now.
Yes, we can.
Okay, great. So I'm going to take a bit of a different slant from what Jim's been talking about. So I'm actually going to present some research. And I'm going to present the results of a multi-site cluster randomized controlled trial in social housing. And I just want to sort of tell you a little bit about me. I've been involved in research in social housing for about 10 years now. I am a family physician and have been for 25 years or so. And I am the lead researcher of the Vulnerable Individuals in Primary Care Research Lab. So the trial I led was quite unusual, and you're definitely going to want to know why and more about it and what it does, and that's what I'm going to tell you. So I'd like to start, actually let me just change the view. There we go, that's better. I'd like to start by explaining a little about community paramedicine, because it's going to be relevant in the talk and you'll see why. It's a new and emerging role for paramedics in Canada. And in this role, paramedics will provide healthcare services to the community, but these will be outside of their traditional emergency response role. So they may respond in collaboration with other healthcare professionals, and the role is about connecting patients with health and community services. And one of the main goals of any community paramedicine program is to respond to community needs. So I want to spend a little bit of time talking about older adults in social housing, because they are a very unique and a vulnerable group with high rates of illness. So literature that my team and I have produced from a pan-Ontario social housing population has shown that this group has a mean age of about 72. They are mostly females. The majority of them live alone, therefore they are very socially isolated, and the rate of social isolation is nearly twice that observed in the same age group of the general population. Around 70% have been educated up to high school or less, and they have very poor health literacy. In fact, in Hamilton, 82% have below the average health literacy score. And falls in the past year were reported by over a third, and fear of falling was felt by 40% of residents. And rates of food insecurity are also very high, nearly double that of the general population. So you can see these are all very serious risk factors that affect this population. In fact, this co-occurrence of multimorbidity paired with lower socioeconomic status may lead, in fact, to a large amount of 911 emergency or EMS calls. And a lot of these calls might be for things that could be better dealt with in primary care settings or in a family practice setting, in fact. So all these factors came together for us as a team, and we realized that there was a very large need for a program that would actually address chronic diseases in social housing, and a robust study to be able to evaluate it. So if risk factors for chronic diseases could be screened for, then the progression of issues that shouldn't be emergencies could be prevented, and these chronic conditions can actually be managed more appropriately. So I already had explained to you about the emerging role of community paramedicine. So because we had done a pilot study of an early version of the CPIT clinic program in social housing for older adults, and that had been a very promising pilot, we thought that perhaps paramedics could actually perform some disease prevention and health promotion if they had adequate and appropriate training. So we then developed the Community Paramedicine at Clinic program. So CPIT Clinic is a chronic disease prevention, management, and health promotion program. There is concurrent CPIT Clinic specific training that was developed by my team and that's specific to the program, and it will teach paramedics how to use tools and perform health education that's specific to this program. The main goals of the program are to reduce the number of repeat 911 calls from social housing buildings, and to improve the quality of life and well-being of vulnerable older adult individuals. And the program is based on community health promotion evidence. So paramedics will actually hold drop-in sessions in social housing buildings, and in these sessions they conduct health risk assessments using validated clinical tools, and they will then provide tailored health education and refer patients to community resources which will help them. And a summary of information will be sent back to the family physician with the consent of the participant. So in order to evaluate the CPIT clinic program in a robust way, we designed a pragmatic community clustered randomized controlled trial, and we executed that, and that took place in 2016. And the following slides will describe the details of the trial. The objectives of the randomized controlled trial were to evaluate the change in mean 911 EMS calls at the level of the social housing building across multiple community sites in Ontario, so not just Hamilton. Also, we were going to evaluate improvements in health-related quality of life and chronic disease risk factors among older adults living in intervention buildings, and we were comparing this to control building residents at the individual level. So a bit more about the design. This was an open label, parallel, pragmatic, cluster randomized controlled trial. And the CPIT clinic program was implemented by paramedic services and municipal housing services in collaboration. And we compared the CPIT clinic intervention to usual care in 5 Ontario community sites, some of which were urban, some suburban, and some rural. And this took place for a 1-year duration. And the setting was social housing buildings for low-income older adults, and the locations of the clusters of social housing buildings were 5 separate municipalities: Hamilton, Guelph, York Region, Simcoe, and Sudbury. So the inclusion criteria for the buildings to be in the trial were that there had to be more than 50 residential units per social housing building. More than 60% of the residents had to be aged over 55 years, because that's what social housing designates a senior to be. There had to be at least 1 matched building of similar size and demographics so that we could have pairs of similar buildings, which we could then randomize to either receiving intervention or control. So the intervention was open to all building residents, although only those aged 55 years and older were analyzed for the results of the trial. Community paramedics led the sessions. They were focused on the health risk assessments and health promotion, disease prevention, as I've discussed. The sessions were conducted in common areas of the buildings, and this was at the recommendation of housing services. And as I've already mentioned, the sessions were weekly, and community paramedics assessed the risk of diabetes, cardiovascular disease, and falls, and then they made referrals to community resources. Individuals were counseled on their chronic disease risk factors or chronic disease management by the paramedics. They were also encouraged to attend multiple times and to drop in again in the future. And these CP at Clinic assessment summaries were given to the participants and also faxed, as I've said, to family physicians to help inform their practice for their patients' continuity of care. So we had two levels of outcomes. The primary outcomes were at the level of the building, and they were meant to, that was meant to answer the question, what's the difference in numbers of EMS calls in older adult social housing buildings receiving the CP at Clinic programs compared to those buildings receiving usual care? And this data that was collected for this was actually collected by the paramedic services who store their 911 call data. Secondary outcomes that I will present in this talk were to answer the questions, is there a difference in diabetes risk status, health-related quality of life, and other health behaviours between older adult residents attending CP at Clinic sessions versus those receiving usual care? And this data was collected by using a research assistant administered survey, which was comprised of multiple validated questionnaires such as the EQ5D. One of the other secondary outcomes was for those attending the CP at Clinic sessions in the intervention buildings, is there a difference in the blood pressure and health-related behaviours? And also this information was collected through the health behaviour survey and also using a standard blood pressure assessment protocol. So the baseline and participant characteristics were descriptively analysed, and our primary outcome of 911 calls were analysed at the building level, and we used GEE analysis techniques to compare mean numbers of EMS calls per 100 apartment units per month, controlling for building pairing within the sites and number of calls in the prior year, and also for the effect of building clustering by site. And for the secondary analysis of the questions that I'm presenting here, we also conducted an individual level analysis, and that was also using generalized estimating equations, and we were accounting for clustering of individuals within regions when we did that. So I'm now going to present the some of the selected salient results from this large trial. I can't possibly present everything because there isn't enough time. So this diagram is really just to show you that in the beginning we had 85 seniors social housing buildings that met the eligibility criteria for the trial. And from that, 30 buildings were able to be matched into 15 separate intervention control pairs, and we matched the buildings based on the demographics of the people living in them, the geography of the surrounding areas, existing services that were provided in the buildings, and the EMS call numbers historically to those buildings. And then one building from each pair was then randomized to get the CP at Clinic intervention. So there were around 2,000 or so residents in the intervention and control groups each. So this slide gives you an idea of the different sites. So sites 1 to 5 are different municipalities. And this really demonstrates that the randomization was balanced, that each of the sites had similar numbers of units, similar percentage occupancy of seniors, and also a similar average number of EMS calls. During the intervention period, 794 intervention building residents attended the program. 715 people attended at least twice, and 644 people attended at least 3 times, and that was the majority, around 80%. So participation rates from buildings were very variable and ranged from about 10% to about 82%, but on average were around 40%. And over 17,000 blood pressure measurements were completed, and over 700 participants had risk factor discussions with the paramedics. and family physicians received 755 automated faxes, which informed them of their patients' risk assessment findings, and this was done quarterly. So the paired analysis of the mean monthly EMS calls while controlling for baseline numbers demonstrated that intervention buildings had a lower mean number of 911 calls compared to controls across all analyses. So the difference was 0.9 calls per 100 apartment units per month. And to just put some perspective on that, that's about 11 calls per year for every 100 units in a building. So thinking about the average 200 unit social housing building, that's about 22 less 911 calls per year. So that was a 19% relative reduction in 911 calls between intervention and control buildings. And just a quick note about the ICC for buildings within sites, it was very low and minimal, indicating that the buildings within sites or regions were very similar, and there was a very little cluster effect on the outcome. So now I'm going to take some time to describe the secondary outcomes, just a few of the secondary outcomes. So we had done pre-intervention surveys in 358 intervention residents and 320 control residents from each of the 15 social housing building pairs. And I'm going to present some of the demographics and characteristics of these residents in subsequent slides. I want you to note that it's quite unusual to have data from older adults living in social housing. Typically, the data we have about older adults is from CCHS or it's from the Canadian Longitudinal Study on Aging. And in these data, social housing residents tend to be underrepresented. So this first slide shows the socio-demographic characteristics, and they were similar between intervention and control participants. But what I really want you to note is the demographics of the social housing population. For both groups, the mean age was over 70. Most were female, 90% lived alone, and 2/3 only had high school education or lower. The next slide looks at the risk profile characteristics. Physical activity was poor and low in nearly half of those surveyed. 1/3 had a poor intake of fruit and vegetables. Nearly 70% had very high body mass indexes. Over half had a high risk of developing diabetes, while 40% had a moderate risk. And smoking rates were also very high, from 25 to 38%. Interestingly, alcohol consumption was quite low, and I think that's probably due to the cost. As I've told you before, health literacy has been found to be very low, and in our sample, it was also very low. Baseline results of cardiometabolic disease were very high. Between 1/4 to 1/3 had heart problems, over half had hypertension, and more than 1/3 had high cholesterol. Nearly 1/3 were known to have diabetes. And these chronic conditions are not really surprising when you consider the high prevalence of the risk factors in the previous slides. And with all these risk factors abundant, it's not surprising that 12% had had a stroke already. So around 40% also reported poor to fair quality of life, and 60% had mobility problems, and nearly half experienced problems with their usual activities. Also, 3/4 expressed pain and discomfort, and half had anxiety and depression. And this data is markedly different from that experienced by the general population. These rates are very, very high. And another interesting factor, 90%, more than 90% actually had a family physician. So post-intervention, we surveyed intervention building residents who had attended CP at clinic and control residents as well. And I'm going to present some information comparing these two groups now. So when we compare the people who attended CP at clinic to control building residents, we can see that although it's not statistically significant, rates of physical activity and fruit and vegetable intake were higher in attendees after the intervention, and body mass index was also less in the attendees, but that also was not statistically significant. There was, however, a trend towards significance in diabetes risk categories, which indicates that diabetes risk in CP at clinic attendees had improved compared to controls. It's not quite significant, but nearly. So this slide compares the health-related quality of life changes between the attendees and control building residents. And you can see that 3 health-related quality of life domains, that of self-care, usual activities, pain and discomfort, significantly improved amongst CP at clinic attendees. Overall, quality-adjusted life year scores significantly improved as well amongst the CP at clinic attendees. This slide is to show you some of the blood pressure changes. 57% had elevated blood pressure during their first visit, and this line graph shows how the blood pressure of attendees of CP at clinic behaved. It decreased across the visits, and the decrease happened fast. Of those with high blood pressure on their first visit, 68% had blood pressures within the normal range on their second visit, and you can see that the decrease in blood pressure is sustained. I'm now going to present a couple of slides just with some brief qualitative results from individual interviews and focus groups that we conducted with participants of CP at clinic. I don't have time to present more, but I really think it's relevant to get an overall picture of the study's impact. Participants expressed that they had received peace of mind, comfort, and family physician support as a result of the CP at clinic sessions. They commented, "To be able to come down, have your blood pressure checked, talk to them," that's the paramedics, "it just made it so much easier and gave you such peace of mind. That's the most important thing that I got out of it, was the peace of mind." Another participant said, "I think it made you feel better when you've been talking to them. If you had any questions, they were answered." Another said, "I was ready to go to the hospital, but no, they made it comfortable enough that I didn't have to use that ambulance." Where implemented in buildings, social participation, social connectedness also increased as a result of CP at clinic. Participants told us that they felt a sense of safety, companionship, and that it was nice to sit out in the hall and wait our turns and talk. And they, the building residents, participated in the sessions, and this led them to participate in other things which occurred in the building as well. They told us, "We were all out here socializing, waiting for our turn." And I think that speaks to the social aspect of the trial, of the program, really. So in conclusion, the CP at clinic program in social housing can facilitate healthcare access for older adults experiencing health inequalities. It was able to decrease EMS calls, improve quality of life and diabetes risk and blood pressure. Of course, there's still a lot of work to be done further. We are conducting more work to determine the sustained effects and optimal frequency of delivery of the program as it integrates within the health system. We're also finalizing a paper that looks at the effects of the program on healthcare utilization using administrative data. And the CP at clinic strategy has the potential, and it's shown the potential to improve health system access for this very hard to reach population, and also reduce utilization of emergency services. So it's very interesting, when the trial had ended, other paramedic services really wanted to implement CP at clinic even before the trial had ended. And there was a natural scale up and spread that occurred. So prior to COVID, this program was actually offered by 40% of Ontario paramedic services, and it was in 118 social housing buildings across Ontario. And those sites are now getting back up and running after COVID. There's also been a lot of interest across Canada and from the US and the UK regarding adapting the program for other social housing situations. And, you know, the program really has potential, can be generalizable to other social housing across Canada, as well as the housing projects in the US and also council housing blocks in the UK. So I just want to say thank you to the VIP Research Lab team. That's Rick, Francine, and Melissa, without whom the work couldn't have taken place. And a special thanks to Michaela, Amelia, and Pornise for helping with the slides.
Thank you very much to Gina and Jim both. So I'm going to take a look through the chat box. We had a lot of interesting questions and comments. While I do that, I'm going to share my screen and pitch the next One Topic, Two Disciplines seminar there for you. And so I'm going to go back to the top here. So one of the first questions, of course, would be directed towards Jim, and sort of questions and comments from Mary Hines and Vincenza Gruposa together. So can you comment on how there's a real flaw in aging in place and how we could switch the conversation toward aging in community, as well as from Vincenza, the idea of promoting interdependence rather than independence as a more appropriate goal. So Jim, I think that one would be for you.
Yeah, I mean, I guess the answer is kind of in the question. So I don't dispute those. I don't dispute the potential of moving those directions. I mean, to me, the chief shortcoming of aging in place, age-friendly cities, is that it tends to focus more on services. And you know, as I said, there's very little problematization of built form. And so a good example of this is the way that we've built communities in the suburbs for the last 50 to 70 years has been to segregate different types of housing types. So we have all the single detached dwellings in one area. We have all the apartment buildings in another area. We have all the townhouses in another area. And we haven't built complete communities where people can spend their entire life cycle. So to me, there's an interdependence between the opportunity to maintain for people to maintain their social relationships over their life cycle and the urban form. In other words, if you want to move to a different type of housing in the way that we currently build things, then you generally have to move out of your immediate area and you can't maintain your local social relationships. And that's so to me, yeah, absolutely. That's I'm open to those sorts of things. I think that the thing is that it's the details matter and the scalability matters a lot.
Thanks, Jim. I'm gonna I just stopped sharing, but I put the link in the bottom if anybody wants to take a look at that. And then I'm going to go to one that's directed to Gina, and this is from Alison Dubé. So she asked how COVID affected the ability to implement this program. So not being able to gather in public spaces, or you know, some of the qualitative comments people had, and whether the lack of social opportunities might have changed the impact of the program.
So it's interesting you say that. I mean, I think there's two aspects of the program. There's a chronic disease management aspect, and there's definitely a social aspect. So we were able to, this is after the trial, we were able to switch the delivery of the program to be a virtual program. So paramedic services have been able to call people up. Few of them, unfortunately, have access to internet and tablets and things like that. And if they do, they're not really able to use them. But the phone calls were a great help. Yes, of course, social impact would be affected. But I think during COVID, if you're an older adult in social housing and you're not going out and you're not seeing anyone, at least a phone call and a connection with a community paramedic is something, and it's better than nothing. It's also encouraging to see that now that things seem to be changing again, as we're hopefully coming out of the pandemic a bit more, that the program is getting up and running again. And it's very heartening to see that the municipalities and the housing authorities really want the program back, and paramedic services are working hard, and they're re-implementing it. I mean, of course, COVID will impact the social the social impact of this, and there's not much we can really do about it, but we've tried to counter it as much as we could.
Thank you, Gina. So Cheryl Allaby asked some questions about how the Hamilton context specifically, and about how maybe Hamilton City Hall doesn't view LRT as a means to help aging seniors, and asks how we might be able to impact this, and noting in particular that there are no stops where we might like to see them, and no plans for affordable, accessible housing along the route.
Yeah, I mean, I can address that. I mean, I wouldn't talk to the politicians about this. I don't think that's I generally talk to the staff, and we're talking about kind of, the housing that will be developed at the nodes on the LRT it's going to unfold over the next decade. So we're talking about a long-term time horizon for sure. And I'm sure they don't see it that way, but I think there will be enough pressure from other institutions to be able to say that we are going to need affordable housing, and we're going to need affordable housing that is transit accessible, and that one good focus would be on aging and housing. So I would imagine that there will be organizations. There's going to be quite a lot of land that is going to be available one way or another. I think the key thing is to make sure that the land that has been acquired by Metrolinx gets a public purpose, as opposed to a social purpose, as opposed to a commercial purpose, is going to be the key to that going forward. And the thing that when I talk to people in the public service at the municipal level, and not just in Hamilton, the thing they say to me is, what I need to know is, what's the magnitude of the problem? What's the solution? What's the cost of doing nothing? And those are the kinds of things, the solutions. And so I think that we have, and honestly, the cost of doing nothing one, I think, is particularly important, and it's not one that we're really well suited to answer in academic research. So I'm actually looking for someone, if anybody knows a good economist who can come up with what's the cost of doing nothing answers, then please let me know. But yeah, I think that's true. And then in terms of where LRT stops I think they'll probably have to put one at Bay Street. I don't see any. It's a pretty long distance from King all the way to Queen, that there's going to be a gap. So I think they'll eventually approve one, but now's not the right time, because just getting it through has been the bigger challenge. And then in terms of relative locations relative to clinics and that sort of thing, clinics will move, right? What we'll see is that once we have those nodes established, there will be lots of activity that occurs in response to the establishment of those nodes, those transit nodes and stops. So not to take anything away from McMaster or anything like that, but I get where that's coming from. But by the same token, I think the thing that will convince people, now this is a council decision, the things that will convince council to have a stop at Bay Street is just the sheer distance between King and Queen, and that's an incredibly large distance for a very populous area, actually, and a place that's going to grow in terms of the number of people who are living immediately there. So it would be a well-used stop at Bay, and it'll also service Cops Coliseum and all the other entertainment facilities that they're investing a big boatload of money into as well. I don't know, did I answer the question, Audrey?
I think so, yeah. So we agree that it's a problem, but it might, if we build it, they will come. And so this is a pretty straightforward question from Ellen Bedone. How are the paramedic clinics at social housing funded, Regina?
So actually, the program's basically it's just the staffing really that needs funding, and so the staffing is funded by the paramedic services themselves, right? Because they have to staff it. It's a very low cost program. The other issue for funding is, where do you hold the program? But then the common area in the housing buildings is the place where you hold it, so there's no cost to that. So, I mean, the short answer is that the cost is subsumed by paramedic services. And I mean, I think the larger question that this kind of hints at is who really should be funding this type of community health program? Because that's a very interesting question, because it's not just paramedic services who are getting the benefit from this. Hospitals will get the benefit because less people will end up going to hospitals. So there's an argument for should hospitals be contributing to this, right? Like I feel like, paramedic services are kind of it's a stopgap, and they're kind of slopping up everything that's happened. Because I feel that, ultimately when a 911 call happens and they have to attend, they're the ones who are dealing with it, right? So they almost have a vested interest in trying to do something to mitigate the problem. So that's kind of why they've ended up paying for it, although I'm not really sure that that's entirely right. And I think housing should really contribute. I think hospitals should contribute. I think there should be some kind of, in the ideal world, there should be a pot that the stakeholders contribute to funding this type of very good program.
Thanks. And to add to that, I have colleagues through interaction with Mira who are paramedics and have told me that these positions at filling these in the community paramedicine clinics are quite coveted, because sometimes it's a physically demanding job, and so if they're injured or if they're pregnant, and a variety of reasons, they might like to take this position up, and there aren't enough of them for the demand from the perspective of paramedics. So I think that they certainly want to be doing this, and they enjoy that type of work, especially when they're not able to do the regular duties.
Can I just reinforce something that Gina just said? And that's the the different silos about who pays for what and who does what. And so there's a very analogous thing to what Gina was just describing in the housing versus healthcare world. So on the housing side of things in municipalities have been saying, listen, we do all this supported housing for people with all kinds of chronic health issues, mental illness and addictions, and so on and so forth. Essentially, we're diverting healthcare, but we're not compensated for it by the big rich cats in the hospital system, is the way that they perceive it. And similarly, the health system is saying, oh gosh, increasingly we're having to develop all these social programs to deal with all these social issues that aren't being dealt with by social services and so on and so forth. So we have a real mismatch, if you like, between the funding and the capabilities of different institutions. And it's really driven by this siloing of these kinds of budgets, right? And so that's part of the reason why I made the point of describing my interaction with Dr. Shah from New York State, because for him, it was all internal economies, right? So essentially any money he spent on housing that had a cost avoidance, he was able to recover that cost avoidance. And what we have right now is we have a system where, with the very rigid siloing, what is done and is needed by one organization in one sector might actually create cost avoided in another sector, but they can't realize the savings of any of those things, and therefore can't grow, right? And so it's actually a bad situation to be in. So this is why I hope that some of the OHTs that are being developed are appreciating this kind of opportunity.
Yeah, and that actually answers one of the questions I might have asked from Jane Tsai, who asked about opportunities for us to learn from the US model and how government policy directions should help coordinate the domains. But I think we're actually at time, and that was really wonderful. I want to thank both Dr. Dunn and Dr. Agarwal today. That was a wonderful combination of perspectives, and so thank you all. I know there's like a clapping emoji or something like that, but I haven't figured it out yet, a year and a half in here. Stephanie has. So thank you again for joining us today. And I had one last chance to plug our very next Mira webinar series. So that'll be Mylena Head and Jeremy Petch, who will be talking about aging, health equity, and the digital divide. So you can register for that at the bit.ly, which is Aging Digital Divide, or you can find it on our website and on Twitter as well. But wish everybody a happy Friday and a good weekend. Thanks very much.
Thank you, everyone. Bye-bye.
Thanks.